Hello guys, welcome to today's webinar. We're happy to have you here. And also today we are very honored to have Dr. Laura Frost to give us some introduction about equine gastroscopy. So Dr. Laura, now is your time.
Wonderful. Thank you so much, Farron. Hello, everyone. Welcome. Just want to give you a little bit of information about myself. I'm Laura Frost. I'm the owner of Halton Equine Veterinary Services. I graduated about 27 years ago from the Ontario Veterinary College. I received my certification in animal chiropractic by driving to Hillsdale, Illinois, pretty much the same year that I graduated. I also do some work as an FEI level 1 treating vet and as a veterinary services manager. And I am also a past dental committee member of the AAEP. A little bit about my practice. Our clinic is situated on our family farm in Puslinch, Ontario. It's about 100 acres. It's located close to Toronto, about 45 minutes away. And it's also close to the Ontario Veterinary College, about 20 minutes away. I'm currently a solo practitioner, but we do have a few specialists that do frequent our clinic. We have been providing gastroscope exams for over 20 years, and I've been involved in a few research studies. Years ago, we were also investigating capsule endoscopy, which resulted in institutions conducting further research. So what is equine gastric disease? There are so many different names that they've given it over the course of the years. But I do like to think of it as an ulcerative and inflammatory condition of the gastrointestinal tract. And why is it so important? We ask our horses to perform to their best level. We put them in stressful environments. We feed them according to our needs, not theirs. Sometimes they give us signs that we misinterpret, and we owe it to them to get it right. Gastric disease can affect 50 to 90% of our horses, resulting in poor performance, but the clinical signs are vague and often mimic other reasons for poor performance, such as musculoskeletal or respiratory disease. You can see this video of a number of fences being knocked down. And at first glance, you might be thinking, well, maybe it's musculoskeletal. You know, is the horse getting enough air? Is it because it's asthmatic? Does it have laryngeal paralysis? But certainly a horse that's knocking a lot of rails could potentially have gastric ulcers. It's a multifactorial type of disease. There's so much involved, everything from stall rest contributing to ulcers, different feeds, so excessive sweet feeds can contribute to ulcers. We also know that feeding a hay that's higher in alfalfa will have a bit of a buffering behavior as well, so it's a benefit. It could be environmental contributing to the ulcers if they've got, you know, a long haul to a competition, or they're, mid-season in competition. Certain diseases can also lend to gastric ulcers. Drugs, we know that phenylbutazone, Previcox, our flunixins can certainly contribute as well. And certain allergies, you know, we think of inflammatory bowel disease as being certainly linked to gastric ulceration. And there's even probably a genetic component. So there's really no magic bullet. It's a pretty intricate, very multifactorial type of problem. So the clinical signs, what are we seeing in these horses? You could see a change in performance, a change in eating habits, reduced body weight or condition, a change in attitude or behavior. But the bottom line really is you cannot look at a horse and decide. So just because a horse looks poor and is difficult to handle or kicks out when you brush near its abdomen, you cannot conclude it has ulcers. And even if acupuncture points can help direct you to the idea that the horse may have ulcers, you still don't need to know, or you still can't determine the location of the ulcers or the severity. So you really need to look with that endoscope. So the purpose of this talk really is to look at the procedure rather than the disease and treatment, but I'll welcome any questions at the end of the webinar. There are various techniques that we use here and what has worked for us. And I really hope that you're able to get something out of this webinar and develop your own technique. So let's have a look. These are the tools that we have in our practice. We have two OHA scopes. One of them is a 3.3 meter, 9.6 diameter, and a 2.8 biopsy channel. We also have a slightly longer scope that is 3.5 meters. It's a 12.8 millimeter diameter and a slightly larger biopsy channel, which is really nice to work with sometimes, and that's 3.7 millimeters. So the 3.3 is slightly slimmer. It's very handy for smaller equines, including ponies and even miniature donkeys. However, I do prefer the larger diameter scope for the average size horse. I believe the extra weight seems to help navigate to the pylorus in some of the more difficult horses. And it's slightly longer, so it gives us just a little bit more length when examining the duodenum. We also use suction and flush with regular water through a vacuum pump, and we insufflate with room air. Just an interesting tidbit of information is that human patients are often insufflated with carbon dioxide. It seems to dissipate through the tissue that much better. Now let's have a look at what we can see. There is just so much more than just looking at ulcers. If we look at the first little video here, you can be looking at the ethmoid turbinates, you can look at the epiglottis, you can look for mucus or laryngeal paralysis, other factors that may contribute to poor performance. So seeing this really is just a bonus during the gastroscopy, and it might even help determine if a BAL is warranted. If you are thinking about that, it's often better to do this before the gastric scope, especially if you're, using the same scope. Another little video here into the stomach. Again, the stomach can show more than ulcers. In this particular video, we can see some bots. You can even see the little spicules on them. Usually they're located close to the margo plicatus and can be found in clusters in some. And occasionally we can also see neoplasia or gastric impactions. And then into the duodenum. You don't need to insufflate when you go into the duodenum. About 10 centimeters in, you're going to locate the major and minor duodenal papilla, and they can be seen directly across from each other. Here we've got a bird's eye view of the major duodenal papilla. This is one of my most favorite videos. And just another video of the duodenum. You should be able to see at the bottom of the screen all the tiny microvilli. There's great definition there. They always remind me that they look like sea anemones. Occasionally, we'll also see lymphoid type tissue here that might indicate an inflammatory bowel condition. Preparing the patient and the client. So there's no feed for a minimum of 12 hours, but often we're fasting them 14 to 16 hours. And I know some clinicians still recommend even 24. We previously have recommended stripping the stalls. You know, we don't want to get there and then find out the horse is eaten and it just kind of wastes the procedure. But really, stripping the stalls, it can get really messy. The horses can slip. Clients don't like the look of that. So we tend not to recommend that off like as a first step. But if we are having trouble getting appropriate fasting, then we will recommend it for follow-up scopes. Some people will also use muzzles just to help prevent them from eating the bedding. Again, it's not something that we typically do, but we do try to schedule it early in the morning so the horse isn't, you know, being stressed out watching other herd mates being fed throughout the day. And if there's even an area in the barn that's kind of separate from those horses, it's something else to consider. I really think it's important that signage is really big and obvious for all staff member to know. It's not uncommon that we'll occasionally go in and someone's just forgot that the horse is off feed. So it's important they know it's not just their hay and their grain, but it's no treats, it's no carrots. In fact, I even prefer them to withhold carrots for 48 hours just because I find the carrot pieces actually seem to linger a little longer than general feed for horses. If the horse is coming in on a trailer to be scoped, I think it's really important that there's no hay that's left in the trailer from the previous shipment, that people aren't coaxing their horses on with a grain bin or a carrot. So just make sure everyone's on the same page there. We do recommend removing water first thing in the morning. If it's not removed, it's not usually a huge deal. We can usually adequately suction out any excessive fluid. It's just when there's coarser feed that we can't deal with that. So equipment setup and personnel. We have a set of stocks in our clinic, but most often we do use a stall just like we would if we went out to the barns. If I'm doing something a little bit more involved, if I'm maybe taking biopsies or I'm dealing with a really severe choke and maybe I'm limited with staff as well, I'll often use stocks in that particular circumstance. The mobile cart is what we use on the road or an endoscopy tower in the clinic, and that is placed on the horse's left side. There is a minimum of 3 people really required for this. I know there's some vets out there that will pass and drive the scope themselves, but ideally it would be 3 people. So you have one horse handler. In our case, we use a twitch, so that person's holding the twitch and is standing off on the left side. There are 2 people on the gastroscope. In our clinic, I am actually the one that passes the scope, so I'm going to be standing on the horse's right side. And the person that's driving it, it's usually the veterinarian. I know it's unusual in our clinical setting, but that person then is standing a little bit more directly in front of the horse, closer to where the cart is. We use both irrigation and suction, and ideally it's powered. And we've got another photo here, just showing it in a little bit more detail. So using the working instrument channel directly for flushing and suction greatly enhances and makes the most efficient use of the channel diameter. This is especially valuable while removing contents from the stomach. And when using the red button for suction, the tortuous path can be blocked quite easily. So it just really helps bypass that. Next picture here, we made this irrigation suction tubing bundle as a way of simplifying the setup. We have a barbed Y adapter that comes to the modified working channel tubing and then extends 2 tubes to the irrigation pump and vacuum pump respectively. If you're making one, just make sure that the vacuum line is rigid enough to not collapse under the vacuum. In the third photo here, you can see our setup. Again, it's to the left of the horse. We often use a bin. You can see here, it's like a deep set Rubbermaid type bin. Um, we'll use that to hold the endoscope. And being in Toronto, we can have some pretty cold weather in the winter, and we'll often have that submersed in a warm water bath and pull that out immediately before passing the scope. So for sedation, there's definitely various drugs that we can use here. My go-to is 10 milligrams of dotomidine for an average horse. When I was doing more racetrack practice, often 5 milligrams would be sufficient. You just really have to know kind of what your patient is all about. If you have the luxury of having sedated the horse previously for an exam, maybe for a dental, that will give you an idea of just what you actually need for that particular patient. In Canada here, we have ramifidine. It certainly can result in less head lowering than dotomidine. On its own, I find it in my practice, it's just not quite adequate for most patients. But I will use ramifidine combined with butorphanol for my BALs. Previously, I was using some lidocaine, like a 2% solution, maybe 10 mils drawn up, and I flush it into the nostril after the horse is sedate. And I don't really do that anymore. I've kind of gotten away from that. But if I had an overly sensitive horse, absolutely, it's something you can consider doing. So further preparation, I go up the right nostril. I want to make sure it's wiped out and clean of any debris. And then the twitch is applied with the handler on the left of the horse. In this little video here, I will get right up into that nostril, but this particular horse is fairly clean. And if you're using a lubricant, it's really important that you're not applying it too close to the distal end. I would probably say don't cover any lubricant for the distal 15 centimeters. We do use PAM here. We don't get paid anything extra for talking about PAM, but it's something that we started using after we were told by a specialist that apparently this is what the gastro specialists use in human medicine. So before that, we were spending all the money on a medical grade silicone lubricant. So I have tried other lubricants other than PAM, but we've always gone back to PAM original. Another thing to keep in mind, I know we previously mentioned about the deeper bin with warm water in the colder months, but also you can consider applying a 4% chlorhexidine soap just to the camera and then wiping it off. You're not rinsing it off, just do a clean wipe, and that will help prevent any camera fogging. There's a paper here also listed on this slide that you can investigate other options too. So further aids, an overtube can be used not only to help prevent bleeding, which is, in my opinion, really rare with gastroscopes, but it's also going to go directly into the esophagus and helping you prevent it retroflexing into the oral cavity, resulting in chewing. No one wants a chewed endoscope. So it's one way of going about that. We have used it for certain research studies, but generally speaking, we don't use an overtube. I have seen other practitioners use a dental speculum or a drop nose band to prevent chewing. Feel it's often not necessary, but really it comes down to the comfort level. Again, no one wants a chewed endoscope. I'm hoping, though, that people feel more comfortable after watching the webinar and realize there's things that can be done to help reduce that risk. So passing the gastroscope, you're going to ensure that the distal end of the scope is straightened prior to placement and that the camera is clean. There's a little video here just showing you. And have a look at the monitor and make sure that the image that you're seeing is acceptable. If it's not crystal clear, you're probably going to want to wipe off that camera. So the passer, again, that's me at my clinic. I have the scope in my right hand, and with the left hand, I'm going to guide it in just as I would if I was passing a nasogastric tube for a colic or a choke. I'm going to direct it ventromedially. And we're watching that monitor the whole time, making sure that we're not advancing into the ethmoids. So this is usually the time the horse is most likely going to resist and toss its head. So the handler should also try to keep the head steady. I usually like one hand on the twitch and one hand on the halter. So the eyes are on the monitor the entire time, and the driver, who's usually the vet, will direct it away from the ethmoids if needed. And if you do see the ethmoids, obviously you're going to stop advancing the scope. So all eyes are on that monitor. And you can see I've got a small towel, so if that lubrication just becomes a little too much, I have a towel that I can quickly access. So the entrance to the esophagus, you're going to go up to about the 30 centimeter mark on your scope, and I'm going to advance it up the right nostril to the left arytenoid. The passer at this point really should be looking away from the monitor. And I typically find if I'm watching the monitor, I have more difficulty in passing it. So I actually go by feel, very similar to what I would do if I'm passing a nasogastric tube blindly. And then when I do feel that the horse has swallowed, I'm going to only advance that scope 10 to 15 centimeters. And this really should reduce the risk of you having it retroflex and go into the oral cavity. So here, again, just over that left arytenoid, it's collapsed. So you're not really seeing a whole lot, and you're just going to go by feel. And you're going to be up against tissue for a bit, so you're not going to see too much for a second or two. And then once you do pass it, that 10 to 15 centimeters, again, you're up against the tissue here, you're not going to see a whole lot, and then you're in the esophagus. So you're making sure that you have located the esophagus, that you're not seeing tracheal rings, you're not seeing any teeth, and if you're not certain, just stop advancing. If the horse is starting to chew, stop advancing and probably come back out. You can also examine the esophagus. Oops, there we go. You can examine the esophagus as we're going down, looking for strictures, ulceration, bleeding, or impaction. Remember, you're insufflating as you're going down the esophagus as well. And the driver is going to try their best to stay within the center of the lumen, so there's less chance of it retroflexing. So the stomach is typically anywhere from about 1.8 to 2 meters to the cardiac sphincter. As soon as you get into the stomach, you should be able to appreciate if you've had an adequate fast or not. If there's significant feed in the stomach, you might consider trying again in 4 hours. or returning another day and fasting again for a longer period. So I think it's important that you figure out if there's been delayed gastric emptying or if it is a true impaction. I think if you have a history of weight loss, certainly true impaction could be high on the list. So here we've got a big food bolus, and you can see quite a bit of the non-glandular stomach and just a little bit of, well, you've got the scope so you can see coming in, a little bit of the glandular, but not much. So looking at this, you're going to have an incomplete exam. You're going to want to insufflate to the point where the squamous portion is nice and smooth. You're not going to be able to get all the folds out of the glandular area, but your non-glandular should be nice and smooth. You want to make sure the stomach isn't collapsed on itself, that you can get a good view. So we're going to do a quick evaluation of the stomach and note any obvious pathology. And then you're going to position the gastroscope to evaluate the pylorus. So remember, we're not able to go directly from the esophagus and down right into the pylorus. Occasionally we get lucky, but you really have to make use of the horse's anatomy. So as you enter the stomach, you're going to go along the horse's right side, over to the left side, and looking back at the cardiac area, you can see the lesser curvature here and the pylorus just below the lesser curvature. And sometimes what we need to do in order to get there is we actually rotate the scope on its longitudinal axis, usually in a clockwise direction. And there's some nice pyloric lesions there too. So the pylorus and duodenum. So you're going to pass through the pylorus into the small intestine. There's no insufflation that's really needed for the duodenum. You're going to be examining the walls for erosions and plaques. Look at this video here. To the left, we've got our minor duodenal papilla, and then directly across from it, you should see that on the right side, the major duodenal papilla. You can see a little bit of bile. And that is typically the major and minor duodenal papilla. Again, it's about 10 centimeters in from the pylorus. If you're going to be doing any biopsies there, realize that a lot of our samples, because they're so superficial, may come back inconclusive. So do take 2 or 3 samples and make it worth your while. Other than that, I do find that findings in the duodenum are relatively rare, but the more we look, maybe the more we sample, we're just going to learn that much more. So the glandular exam. So upon exiting the pylorus, we're going to examine the folds for any lesions that may have been missed. In this little video here, you can see some nice fibrinosuppurative lesions, and you can also play around with different wavelengths just to help identify the actual edge of the lesion. And if you look at the lesser curvature on the way out, it's important as this is the most common site for squamous ulceration. And you can see how irregular that edge of the margo plicatus is, which is definitely within normal variation and much smoother actually further up in the same stomach. So I have a picture actually of doilies here. And the reason I have that is I find they're very similar to the way I see variations in the margoplicatus. So it can be anything from a very smooth, straight line to a very scalloped, irregular edge. As well as there can even be some small holes that are closest to the margoplicatus that shows the glandular mucosa underneath. So I think it's really important that you understand all the variations and you don't confuse a normal finding actually as an ulcer. So now we're going to be looking at the squamous non-glandular exam, and this is when you want to be using a lot of your irrigation to clean off the epithelium. Don't forget to look up and look all around the cardiac sphincter. You should be able to see your scope at this point in time. And I have two videos down here just to stress the importance of rechecking after you've done treatments. Anything can happen when you're not looking. If you look at this first little one, we've got a polyp, but the actual tissue itself looks quite normal. And the histo back that came back on this showed mucosal hyperplasia, otherwise known as a polyp, showing normal epithelium. If I look at the second little video here, this is an older video, but it's showing a squamous cell carcinoma at the margoplicatus. Again, stressing the importance of these rechecks. This was probably close to 8 weeks after we had treated this horse for grade 4 ulceration. The ulceration was so severe, let's play it again, that we actually didn't see this when the horse first presented to us. We did use electrocautery through the biopsy channel. I think it took about 3 passes, and it was pretty in line with the rest of the tissue at that point. The horse did remarkably well, was confirmed with histo to be squamous cell carcinoma. So exiting the stomach, before you do that, do not forget to deflate it. You've already put in a bunch of room air there. You don't want to be having to go back and look after a colic. As well, you want to, as you're exiting the stomach, look at the esophagus again, the laryngeal area, the nasal passage, for any possible injury that might have occurred passing the gastroscope. Disinfecting and storage, we use an enzymatic cleaner. It also has a rust inhibitor, and our disinfectant that we use is accelerated hydrogen peroxide. You're also going to want to rinse the biopsy channel and the air water with alcohol. And the little picture down below here is just showing a small air compressor. It sits on our counter, and we'll actually connect that after running the alcohol through it for about 10 minutes, and it's then considered quite dry. There are processors available, if you're a very high use clinic, but it's unlikely needed for our smaller clinics. Once the channels are all dry, it can be stored back in its case, or if you have exceptionally tall ceilings, you can also hang it to dry. So just a few extra thoughts. Occasionally you'll come across some horses that are just not going to have anything to do with having a gastric exam. It's just not worth the risk. We've come across probably a couple, in all the years. We've probably performed well over 1,000 exams, but we just weren't able to complete the gastric exam for whatever reason. One gastric exam is only a small shot in time, and although the patient may be normal that day, it's not going to predict the gastric health for that horse in the future. Problems come and go, and you have to have to redo a scope, if they're looking like there's a change, 6 months or a year. You just can't base it on the previous scope 2 years before that. The seasonality, you can have certainly higher incidence of gastric ulcers in peak show season, but there are horses that actually are quite stressed during the colder months and during weather changes. So don't forget about the winter months as well. And I really want you to just keep practicing, be patient, expect there's a learning curve, don't get discouraged. Okay, we've all been there. And again, the bottom line is if we don't know, or we don't know if we don't look. So keep scoping, and I hope you learned a little bit from our talk today. I'd welcome any questions.
Thank you, Dr. Laura, for the sharing. And if you have any questions, you can type in the Q&A box. And right now, we actually have questions raised from the audience from Dr. Andrew. So, doctor says we know the gastroendoscopy is can normally do for the recurring colic, but the doctor's concerns is because you need to do the fasting. So, is it the time will be too long for the horse without food in order to do the gastroscopy? Can have the risk for the horse have another colic like after the gastroscope?
Yeah, no, that's a great question. I haven't experienced that myself. Um, I think it's a relatively low risk, and certainly I probably fast them a little bit less than what a lot of other people do. If you're that concerned, I would probably try at 12 hours and see if you got, an adequate picture. If there's a lot of feed in that stomach still, then maybe you try it another time. But I haven't, and I'm knocking on wood here, that I haven't had horses colic because I've investigated them through gastroscopy. Hope that helps answer that.
Okay. Any questions from the audience? You can type in the question box.
I think just if there are any other questions, I thought I would just elaborate a little bit on the squamous cell carcinoma case. That was a horse that was actually coming three. It was a racehorse. Um, and I think we usually don't think of squamous cell carcinoma in such young horses, but that was an exceptional case. And actually did continue to race for at least a year after, of which time I did lose uh, the information on the horse, so I wasn't sure what was going on after that, but did incredibly well.
Mhm. Dr. Miranda have a question. Can you repeat the size of the scope you use for the equine gastroscope?
Yeah, I have two scopes. One is 3.3 meters. The other one is 3.5 meters. And let me just go back to this exactly. There we go. So the 3.3 meter one has a diameter of 9.6 and a biopsy channel of 2.8. The 3.5 meter scope is a 12.8 millimeter diameter and a 3.7 millimeter biopsy channel. Yeah, so can you still see the slides?
No, they can't.
No?
No.
Okay, sorry. So the one is VET, so vet dash 9833HD. The other one is vet, so VET dash 1335HD.
From your opinion, we'd recommend, because I recall you telling us the 3.3 meter is normally suitable for some, I think, ponies, right?
Yeah, the
Or,
smaller diameter one,
yeah.
absolutely. The
Mhm.
9.6, we've used them in miniature donkeys, ponies. It's just a little bit user friendly. It's not, quite as thick. Um, yeah, it's just nice to have the option. Certainly, when we were doing our research, we required to have a backup just in case there was any delay. But yeah, we really like both scopes, and it's just nice to have that option.
Mhm. Uh, Also, we have another questions for Dr. Jose. Does it make sense to administer omepraz omeprazole before a fasting period to reduce the negative effects associated with fasting?
Well, I haven't done that in all this time. I'd be concerned if you started doing any treatment that you may make the patient actually look better than what they truly were. I think if it was one dose, you're probably not going to get into too much, but if you were to treat them for 3 days and then scope, you could have a significant difference. I would prefer not to be quite honest, but yeah.
Okay. Any questions from the audience? Okay. I think for now, no more questions from our audience. Thanks again for Dr. Laura's sharing, and we hope to see you next time.
Thank you for having me, Baron. That was wonderful.
Okay. And thank you so much for our audience coming. For more webinar information, please follow Alhua Vet's Instagram or Facebook or LinkedIn account. Thank you so much.
Thank you.
See you next time. Bye bye.
Bye bye.